Is it Bernard on there? All right, remember to turn your mics on when you talk. All right, call the meeting to order. We're going to do roll call. Charles Cavell. Laurent Coleman.
Here.
Colleen Crossy. Benny Greenwald.
Present.
Sarah May. Tanisha Moore. Michael Spitz.
Present.
Shelley Taub. Pamela Turan.
Present.
Dennis Yeager.
Present.
All right, I would like to amend the agenda such that we will move number 5, or be moving 14A up to after number 5. So 14A is discussion on the open board positions. And I want to move it after 5, board member roles, et cetera. So do I have a motion to approve the amended agenda?
I'll make a motion to approve the amended agenda.
Second? Second. All in favor?
Aye.
All right, motion passes. Anyone from the public like to comment? All right, Bernard Hooper. I will call you to speak. Oh, okay. Okay, well then I guess we come to number 14A, which is 1 open board position, and we have 3 eligible applicants for review. So I'm hoping that everyone had a chance to look over their applications, and I'd like to open the floor for comments on, do we have any of the candidates here?
That's my question.
Okay. I'd like to open the floor for comments and discussion.
Sorry, I need to find them.
Were you raising your hand?
Yeah, I was gonna ask if any were here for comment or online that wanna speak before we have this discussion. I think it's only fair, but if they're not, that's okay. Because I'm ready to make a motion.
Yes.
How many people, how many vacancies do we have?
1.
Okay, thank you.
All right, anyone else? They should be in the packet, but they'd be near the back because we, middle-ish back because we amended the agenda. So they're just a few pages from the back.
Find them.
Did you? Yeah, you found them. All right, I will give everyone a couple minutes if you hadn't looked at them, but you're going to have to look at them pretty quick.
I'll make one. I'm ready. Make a motion if everybody else is.
Okay, yeah, is everyone ready? Any comments on the applications? All right, I guess this is going to be quicker than I thought.
I'd like to make a motion to, is it appointment? What do we phrase it as? I'll make a motion to appoint Susan Bartley to the open position.
Do we have a second? Second, so all in favor of Susan Bartley? I'll do a roll call vote, I'm sorry. Well, I'm just gonna call everyone, because I think people came in late. Charles Cavell, LaRon Coleman. What was that? Okay. Colleen Crossy. Benjamin Greenwald. As of now, unfortunately, I'm going to abstain. Okay. Sarah May.
Yes.
Tanisha Moore. Michael Spitz.
Yes.
Shelley Taub. Pamela Turan. Dennis Yeager.
No.
All right, do we need, so does this need to work that, like, is it just a majority for this? Like a simple majority? Okay.
I'm gonna actually amend mine as of now to nay, just because I see the other candidates that I wanna.
Okay, so,
Not in principle yet, but I just need more time, but if you need to go ahead, you'll go ahead, but as of now.
right, okay. So we have 5 in favor and 3 against, so motion passes. So our new board member is Susan Bartley.
Charlie, you're up here.
All right. Yes, I figured that one out. Let's see, where are we now? Oh, he is. Okay. We have Bernard Hooper with board member roles, fiduciary obligations, and responsibilities.
Hi, good afternoon. Please pardon me for not being there in person. I have a sick child and I need to be home with her today, unfortunately. But I can still share with you the information that you need. I am the Chief Corporate Compliance Officer and Diversity, Equity, Inclusion Officer for OCHN. And I provide generally oversight to board members regarding their roles and responsibilities. So in what will be a relatively quick session, perhaps 5 minutes or so, I'd like to talk to you about the kinds of things that are appropriate for you to engage in within your meetings, the fiduciary obligations that you have, where those fiduciary obligations are separate from the executory obligations of the management team, and how you keep yourself from getting into that gray area. So, generally speaking, your board, as it is aptly named, is an Oversight Policy Board. And in general, boards for quasi-governmental and governmental entities are responsible for policy and direction. With respect to execution and strategy, those are the responsibilities typically of the executives and managers of the organization. The reason that that line is drawn, and it's very much a bright line, is that it emerges from a well-established area of law regarding what board members are responsible for, and the obligations that they have. So there are fiduciary obligations associated with being a board member, and they have to do with your obligation to work and participate in all things in good faith, and also to conduct yourself without conflicts of interest, and to discharge your responsibilities to the best of your ability. So with that in mind, I'd like to explain that in circumstances where you will receive communications from individuals, and this is a very common component of your role, and particularly what we would expect from board members on this board, as well as the other boards that we have, is that you would receive communications from individuals in the community that you would also receive communications from providers in the network. Many of you have provider roles and understand that quite well. And the basis for that is that we want you to be informed and to be an ambassador for the organization. With that said, we do not want you to take that information and use that information independently beyond your role of developing policy. So there are going to be certain things, for example, each of you received, I understand, a letter from one of our providers regarding rates that they received, and that is information. Um, but it's more along the line of facts for you. So you know that it is us that this information has been provided. However, it is information for the executive team to opt on because they are responsible for establishing the rules, executing contracts, developing RFPs, and entering into those contracts according to pricing that is appropriate for our budget for the services we provide. For you, as a board member, it is important for you to understand that your role is to establish policy and to provide guidance and oversight to the executive team and the management as they undertake those operations. Now, why is this important, and why is it important that these roles remain separate? Well, in large part, it's because um, there is an opportunity for you as a director to incur liability if you go beyond your role. And the liability that you could incur would not necessarily be protected by directors and officers insurance. So I don't know if all of you are familiar with D&O insurance. I know Ms. May has heard this presentation, so we've talked about this before at other boards. However, the directors and officers insurance covers them or acts that are taken in good faith within the scope of their role. And so, to the extent that you undertake your role as a policymaker and an oversight provider for the operations of the organization, you would be within your role and protected both legally and by insurance for the decisions that you make. We, on the other hand, as the executive team and managers of the organization, would be covered for our decisions within our duty to the extent they are in compliance with law and consistent with the policies of the organization from liability, personal liability, and the discharge of our responsibilities. Um, and probably the best example of that is if you've noticed, and I'm sure you all have, I mean, you're all very savvy business people. You've all noticed that when you sign a document, you sign it at work in your capacity as whatever role you have. And typically you sign it and then your title is underneath, as is my title here on this slide. Now, that is because it ensures that the party that reads or receives the information knows that you are delivering that information in your role or capacity as an officer or manager of whatever organization you have. However, with respect to board members act differently, and therefore their responsibilities are measured differently as well as the limits of their liability. So that is one of the things that I wanted to share with you. So the second thing I wanted to share, and this is more of a practical approach to being a board member. And I know that you just selected a new member, and so obviously they're going to go through an orientation and need to understand this as well. Is that one of the things that being an ambassador for the organization leads to is the opportunity for people to take advantage of what they perceive is a shortcut or the provision of some kind of benefit to them as a result of sharing information with you. So that their belief would be that you would then therefore bring that information to us, and we would feel more obligated to act because the information was raised by a member of a board. However, and this is not a slight, nor is it intended to sound in any way that we do not respect the role that you have. However, we conduct ourselves in a manner that is responsible and that is professional, and we do so without regard to the source of information that we receive. So, with that in mind, we may be guided by the policy or oversight that you provide us. However, the facts that we receive, which we use as information to make decisions, it doesn't matter if it comes from you or it comes from any other person within our network or any individual that we serve. The rationale for that is that not all facts are necessarily information, but the facts that we use to make decisions are information, and that information can come from many different sources. However, some sources are less credible than others, and that has to be taken into account as well. So it's important to understand that some information will be delivered to you, and it may be the case that you deliver that information. However, it would not necessarily be appropriate to deliver that information to the executive team and management in a public meeting. Some of that information is operational, does not need to be disclosed in a public meeting, and would be more appropriate to disseminate it to your board liaison. And that is typically what we recommend, and that is the practice that we have in the bylaws of the larger organization as a whole. So best practice is that when someone approaches you or when you receive a letter, as you did most recently, that you would take that letter and you would share that letter with the liaison for your board, and that you would allow us to discharge that responsibility accordingly, and to investigate those facts, determine what part of those facts are going to be information and how that information is going to impact the decisions that we make. In some instances, that information may be very valid, but may not impact our decisions because there is nothing that we actually needed to do or nothing that was done that was wrong or incorrect. Or there could be a circumstance where we could benefit or maximize a practice or a policy, and we would do so. But I do not want you to feel that because someone delivers information to you that necessarily they have not been heard previously, that they have not reached out to us previously, that they're informing you of something that we don't already know, and that they may or may not be taking advantage of your role to try to impose some additional benefit, try to annul some additional benefit to themselves by sharing that information with you. So that is what I wanted to talk to you about today. There are a number of other things that we certainly could talk about, the most important of which is the Open Meetings Act. I believe you are all familiar with it and have an understanding of it. It requires that all of our meetings are open to the public, that there is notice of those meetings with respect to all meetings at least 18 hours prior to that meeting, and that there are few and very specific exceptions to that in which someone can go into closed session to have a conversation. When that happens or when something like that happens, it is highly recommended that prior to that, both our legal counsel as well as myself as compliance officer would be involved in that. And there are reasons to do that, which in large part have to do with if the board does go into closed session in an inappropriate fashion or regarding an inappropriate subject, there can be liability that arises from that. So with that, I think I've shared with you a fair amount of information in the 5 minutes I said I would. And does anyone have any questions?
Sally?
Yes, I'm a bit confused on this because there are people on this board who happen to be politicians, there are two. But the rest of us are people from the public. We're not running for office, we're not looking at anything except our position on this board. And if I get a letter from one of the people who live in this county complaining about something, whatever it may be, I intend to share it with the director, but I also intend to share it with this board. I don't think it ought to be a secret. I don't think it ought to be hidden. We are a public entity. Now, if it's something that's nasty or awful or vile or something, of course we don't want to share something like that. But I think it's our responsibility as board members to bring forth to this committee, or, and obviously to our director and to Megan and so on, whatever complaints or issues we have. Can also throw in a few other people we can bring you to. Probably, I don't know who else would like to do, but let me put it this way. People are writing to us because they obviously can't seem to get through to somebody here. That doesn't happen very often. First time it's ever happened in all the years I've been sitting here, okay? But it happens, and they are the public, and they're paying your salaries, and they're paying our, whatever they're paying for us as well, and I think they deserve a fair hearing. I wouldn't bring it to this board in an awful way, but I think I ought to be able to email or text or whatever I want to do, or pick up the phone and at least call Kelly and say, Kelly, hey, I got a letter. This sounds crazy. Pardon me for using that word. Doesn't fit in with what we're doing, but why don't you check into it? I think this is something that should be done and not looked at as something secretive and, oh my goodness. The other thing I want to say is that we, as a board here, we approve your budget. I understand the big board up in the sky does that too, because they have the overall thing. But we're supposed to be a separate entity, okay, somewhat. And so I think we should be approving a budget, and if we have any questions about that budget, it's our role to ask, or our role to contact, sorry, Sarah, yell at Sarah May over here, who represents the Mental Health Board, and say, Sarah, what is going on with your budget that you're not giving Mary Smith enough funding to run her operation, okay? Whatever, I'm just making that up. But I think that's our job sitting here. I don't think we ought to be ashamed of doing it or hide things behind doors. I really don't like that approach. Thank you.
Okay.
Thank you, Shelley.
May I respond to that? So first of all, thank you again, Shelley, for that comment. Actually, that is in fact correct. There isn't anything that we are hiding. If you do receive information, as I said, we would like you to disseminate it and to send it to your board liaison, because when you receive information, all of the board members need to know that you received that information. And so typically the board liaison would then disseminate that information to all board members. So it wouldn't just be to the chair of the board, but it would be to all board members. However, as I said before, there are certain things that don't necessarily rise to the level of a discussion in a public meeting. So it's not that it's secret, it's that it doesn't necessarily rise to the level of discussion in the public forum, because it is not a policy issue or an oversight issue. It's more of, if you will, an operational issue. And so if there is something that does arise, for example, and you brought up an excellent point, which is questions regarding the budget or budget conversations. Those budget conversations absolutely do need to occur, and they do need to occur in a public forum. It is the money that we spend. It is how we spend it. It is the money we receive and how we receive it. And those discussions are appropriate for a public meeting. But what is also important is to understand that certain types of communications among board members, if they exceed the number of board members that would constitute a quorum, would be considered to actually constitute a meeting. And so, in order to avoid having that occur outside of the rules of the Open Meetings Act, we would prefer that if you do receive a letter or something of that sort, that you send it to your board liaison, and then your board liaison can distribute it to all of the board members as appropriate. So no, we do not bury information, nor do we hide information. Actually, we're not capable of doing that. The only information that we can actually not disclose to the public is information that has to do with the individuals that we serve, and information regarding our employees, specifically their HR files. Almost everything else is public information and is subject in large part to FOIA. And we answer multiple FOIAs over the course of a year. So there isn't any intent to do that. The intent is really to make sure that information is distributed appropriately, and that information, while being distributed appropriately, is discussed in the correct venue. So the fact that you all have knowledge of it does not mean necessarily that you all need to have a discussion about it in a public forum. So did that clear up your concern?
Somewhat.
Oh.
Thank you.
Sure. Are there any other
Does
questions?
anyone else have a question or comment? Colleen had her hand up first.
Thank you, Madam Chairman. I am wondering two things. One, I think we all received a letter of concern from a previous vendor or contract where they felt their request for money was mishandled. And then the second one is, who is our liaison? If we get information that perhaps no one else has, do we take it to the chair and say, what do I do with this? And
Actually, I believe Megan is your liaison, and that information should go to Megan. Regarding allegations of impropriety or things of that matter, as the corporate compliance officer, it is my responsibility to investigate those matters. I do investigate all of those matters. The outcome of those investigations, typically, depending on the nature of the allegation, is either, if it is something that is operational in nature, we will handle it from an operational standpoint. If there is something that has to do with policy, we will disclose that information to board members. But in most instances, very rarely will it be in a public meeting. If it is something that is subject to the exceptions of going into closed session. That's an area that is very much hypothetical. So we would have to have very specific facts in order to deal with that. So for example, the letter that you received was regarding, as you said, a particular provider. That information has already been received by us. It has been reviewed by the compliance officer, by legal, by our contract team, by our SUD team. So there are a number of different components of the organization that are responsible for oversight and review of that. And it is not something necessarily that the board needs to take up and handle individually. It is an operational responsibility.
okay, and a follow-up, I didn't hear the name of our liaison.
It's Megan.
Megan.
Well, okay, so
Carolyn?
someone's replacing Dawn, so it would be Dawn's role, except there's a new person in her role.
Right.
Awesome.
Yeah. Yeah, I sent the letter immediately to, I think just Megan or Megan and you. Yeah, I sent it immediately to them, so.
Thank you.
All
Sure.
right, Mike.
Yeah, thank you, Madam Chair. My recommendation would also be anytime anyone on this board receives anything, that it should also go through the chair and then through our liaison. Because that way, the chair can make decisions on if it should be on our agenda or not, because the chair controls the agenda, no matter what it is,
Thank you.
right? And then, if I could also ask Mr. Hooper, you covered a lot of different categories there. Is there any way that you could put that in like a 2-page summary?
I can give you certainly a summary of the Open Meetings Act. And I can
No,
also
just
give
that you,
some-
because you touched the Open Meetings Act, and you touched closed session, then you touched, distribution of data, what we should and shouldn't be doing from a policy perspective. So I just like to see it in writing, all those topics that you touched. There's a few of us that probably fully understand everything, but I'm not sure everybody on this board understands everything that you talked about
Not a
over the
problem.
last few minutes. So I just think it'll help everybody understand it a little better.
Not a problem at all.
Thank you.
Yeah, I'd agree, because I don't completely know the difference between, like, policy and organizational. So it would definitely help me, and I'm the chair, so I'm sure it would help other people.
Yes, I understand. It does not, it is not intuitive. But once you get a clear understanding of a policy, then you get a clear understanding of what's operational. And I try to give the the best example is policy is what you think we ought to be doing. Operational is how we actually do that. And so you are collectively here for policy, which is to help us determine what you think we ought to be doing. And we are then to determine, once you tell us what you think we ought to be doing, to determine how to do that. And then we report to you on regular basis. We provide reports. Megan provides reports. And that is your oversight function, where you actually have an opportunity to receive information from various members of the organization regarding how what we are doing and how our performance overall is moving toward the policy that you're designing and the objectives that you think are appropriate for the SUD portion of our organization to achieve. So that's usually the easiest way to say it. So it's the difference between what you believe we should be doing and then how we do it. So that is the difference between policy and execution or executive function.
I have one follow-up question, Mr. Hooper.
Yes.
You mentioned a couple times about fiduciary responsibility. I believe this board has the responsibility to approve a budget for our scope only. I know the committee of the whole
Yes.
approves the budget for the entire organization, but we have a small chunk of that, if I'm not mistaken.
That's correct.
Okay. Just want to be clear for everybody.
Right. And to the extent that you operate with respect to that budget, make decisions with respect to the disposition of that budget, you have fiduciary obligations to do so in good faith.
Yep. Agree. Thank you.
All right, anything quick, any other quick comments, because we have a full agenda and should probably move on. All right, let's move to our next item. Megan will introduce a provider presentation.
Thank you, Kelly. Today we have here Oakland Family Services. They are one of our contracted SUD providers. Emily Manzigo, she is the Assistant Director of Treatment Services. You can come on up, Emily. Just to give a brief overview while Emily is coming up, so OFS, they provide adult and adolescent outpatient SUD services within our network. They are also a SUD health home and opioid health home provider. They are also our outpatient women's specialty provider. So they provide specialty services to pregnant, parenting, or the primary caregiving parent. And they will go further into the discussion about their services.
Well, Megan said everything, so I'm good. I'm Emily, as she said. I'm the Assistant Director of Treatment Services with Oakland Family Services. You can't hear me. Sorry. There we go. Is that better? I first wanted to say just a little bit about Oakland Family Services. Now I feel really loud. We have been an organization that's been around for over 100 years. Our main areas that we provide services in is education, prevention, and treatment. So education, we have a lot of early childhood services. Prevention is our foster care adoption team. And then treatment is what I'm here to speak about. We can go to the next slide. So with day, and we have two treatment sides too. So I'm going to speak about day one. We focus on mental health, substance use, and co-occurring treatment. We use research-based practices. We treat anything from anxiety, depression, trauma, adjustment disorder, substance use disorder, kind of the gamut of things. We don't do a lot of severe and persistent treatment. We leave that for the community mental health department. We see ages 4 to end of life. So we have providers some that specialize in younger, some that specialize in older populations, and then some that are willing to do all of it, which is a fun day, having someone very young and then someone very older. Our treatment services, we like to say that they're convenient. We have offices in Berkeley, Pontiac, Walled Lake, and then we also do telehealth services. So with our general population, we have clients that are up in the UP that we can provide telehealth services for, so anywhere in Michigan. And then our county-specific SUD, they have to reside in the county. Professional, all of our therapists are master's level. We also have a peer support specialist. Carly will kind of talk about our PRISM program that has more staff also, other than just our peer. We are trauma-informed, we're personal, we use personal-centered planning, meeting the client where they're at, working on the goals they want to work with, while utilizing motivational interviewing to kind of help them see what some of their best routes are. We're connected. We work with other agencies. We try to coordinate care with the client, with either their primary care physician or the courts or their school, whatever it might be, to help them. We can work with the whole family and do family support along with just working with the individual. We are accredited through COA. No one really cares. Everyone cares. It's a big deal, but for this. And we're accessible. So we take almost all insurances. There's a few that we don't take, and then we use county funding for our SUD, for our block grant, and our Medicaid clients. And then we also have a sliding scale if someone doesn't have insurance. Our 4 kind of main programs, but they're very fluid and people can kind of go back and forth between them. It's not, if you have a mental health therapist, then you won't have a substance use therapist. It's very fluid. So we provide mental health treatment, again, from age 4 to end of life, from anything that a lot of PTSD, a lot of just adjustment disorder, any level of substance use disorder also. Our PRISM program, Project Recovery Intensive Services for Mothers, Carly's going to talk more about. That is our women's specialty program that, as Megan said, we have a specialty program that works with substance use with any pregnant and or parenting mother or primary care figure for a client, for a child. And then we also do adolescent substance use treatment and adult substance use treatment. We have a wide variety of groups that we provide for our clients, both mental health, substance abuse, and co-occurring at not all ages, I shouldn't say that, but we have an adolescent group, an adolescent co-occurring group, and then we have adult groups also. I have a slide about some of the things from our recent SUD survey that some clients have said. I feel very supportive. Thanks for your help. I enjoyed every minute being able to share and relate with everyone. My therapist is awesome, very helpful, and easy to open up to. We yearly do an annual breakfast, and we have a client that comes, and this is for the whole of our department, and oftentimes it is someone from our day one department, just because of how much of an impact that department has on the clients we serve and on the community as a whole. Our day one program also, we do an intensive outpatient service. So that's substance use treatment, that's 3 groups a week, 3 hours of group each time. So it's 9 hours and then an individual. So it's really 10 hours of group a week. Sometimes due to staffing, that's not always running, but we want it to always be running. So it's about getting the right clients in at the right time so that we can start it and sustain that group. And I was going to say something. Oh, we also have psychiatric services. We have a psychiatric PA who is a full-time staff member. So it is all that she does is work with us. And she does monthly meetings with our staff on case consultation and is very available when needed. And then Carly's going to talk about PRISM.
Hello, I'm Carly. I'm the PRISM outreach worker, and kind of like Emily said, the PRISM stands for Project Recovery Intensive Services for Mothers, and then some information about our program. Next slide. Don't mind going to the next slide. Okay, there we go. So our program is a comprehensive and intensive substance use program that assists mothers and pregnant women in the development and maintenance of substance-free lifestyle. Engagement in our program helps the women obtain the necessary skills and education and resources they need to generate healthy lifestyles and rewarding relationships with their children. Our program is motivated to empower the women to achieve their goals of sobriety, completing probation and family reunification. So some of the services that our program specifically offers is a comprehensive clinical assessment, individualized intervention planning, case management assistance, also on-site childcare and transportation to and from treatment services. We found those are some of the biggest barriers for women to receive treatment. So we like to provide those for them. Also, we have parenting skills education, financial and housing assistance, domestic violence and sexual abuse treatment. Also, like Emily was saying, psychiatric and other medical services. We also provide free urine drug screens and preliminary breath tests to our clients. And one that's not up there because it's newer, but a big thing is the peer recovery coach that our clients can see and talk with weekly, which is really great for them to do additionally to our program. And then our therapy services for our program is individualized counseling and group therapies that are centered around substance use treatment. Our groups are held on Tuesday, Wednesday, and Thursday, and they focus on substance use, parenting, relationship issues, affect, mood management, life skills, and women issues.
One of the kind of best parts, I think, of the PRISM program is the groups and that cohort that is developed, that these are ladies that are going through a lot of similar things. We get a lot of referrals from CPS, or the courts. A lot of our women in this program are not self-referred, that they are referred by another entity, but they're going through similar things. So they're able to talk to each other, rely on each other, have that shared sense of community, and then have that shared education too. The program has been around for a while, so we've worked really hard to look at what are some similarities to what these ladies are going through, and how can we make sure that those are a focus of their treatment.
Yeah, and then just some other information is that all of our clinicians are master's level therapists who have experience working with individuals and individuals and families that have been impacted by mental health and substance use issues. Attendance for our group is required in individual and group therapies. We really try, as my job in outreach, we really try to communicate and engage the clients in our groups and receiving treatment by our therapists. Also, we do require a urine drug screen monthly for our program, and like Emily was saying earlier, our program does accept most insurances, and then there is funding available. And then these are some of just our client testimonials. One said that I would recommend this program to any woman who truly wants to recover. Through their care and understanding, I was able to help myself not only physically, but mentally as well. I've been treated like I'm really worth something. I believe the PRISM program is the best place for me. And then another client said, the group sessions made me feel not so alone. I learned a lot from the therapist along with the other women in the program. The tools that I learned have helped me deal with problems in my life the right way. The program has helped me build my confidence to be a great mother and the person I was meant to be. And then if anyone has any questions about the program, my contact information is there. I'm always available. Also, we do have a intensive outpatient program that clients can be enrolled in, and we are accepting referrals for that. And they can contact our day one intake and insurance verification specialist, or I can also help interested clients get involved. And we also have some flyers and brochures available and our referral form for anyone that's interested in day one or PRISM programs.
Thank you very much. Did anyone have questions for our provider? Shelley.
Thank you. I know that Jamie Clayton is running some very good programs, and you have a stellar reputation, but I have one question. I like that 10-hour-a-week program that you spoke about. However, 10 hours out of about 160 some odd hours in a week doesn't cut it. Do you refer people also to 12-step programs?
For sure.
Okay.
Or some support group.
Okay.
So Smart Recovery, and our peer is really good with that too, that she's being trained in SMART, so we've had in the past with our peers, have them run Smart Recovery at our facility. So definitely encourage them to get involved in some support, whether there's now a million different types. Celebrate Recovery, Smart Recovery, AA, NA, whatever it is. We know that just seeing us, even if it's IOP for 10 hours, is not enough. And if it's outpatient for maybe 2 hours a week isn't enough. So making sure people are making real lifestyle changes and having support doing that.
Okay, thank you. Thank you.
Anyone else? Colleen?
All right. Very nice to meet you, because I'm a LMSW as well, and some of my clients will say that their 10-step programs can be very male-dominated. So it's nice to have to know of a program that offers support for female treatment-based problems, if you
Mhm.
want to call it that. Anyway, you were talking about your, I don't know if it's barrier to treatment or where you get your referrals from. Do you have some women whose perhaps barriers to treatment would include fear of their children taken away? And if so, what kind of supports, or do you have liaisons with the court, or what's going on there?
So yes, that is a barrier for treatment of the fear of getting their children taken away. We recently had a mother that did not disclose a pregnancy because she had a fear that once she gave birth that they would take away that baby if we got CPS involved or anything like that. So she was in treatment though with us, and we look at and we share with our women that like we have a success rate of keeping families together, and that is our goal of either reunifying children with their mother or their family or whoever, or keeping them in the home. So we talk about that with our women, but also we have to be honest, if there is anything going on, we have to report that. So we have liaisons with Carly's our outreach worker, so she talks to CPS and kind of talks to them to get referrals. We work with a lot of courts and a lot of treatment courts too. So, yeah, did that answer?
That's great. Thank you.
Yeah.
Rabbi Benny?
Yeah, thanks for your presentation. Two questions over here. You mentioned about a psychiatrist on staff. Do you have could patients see the psychiatrist? Because you mentioned that they're kind of of a oversight role of the other therapists, but do you offer psychiatric services?
No, their main, so Emily is our psychiatric PA, and her main role is seeing clients. So that is what she's there for, but she also is an assist to our clinicians.
And on average, what would you say the wait time to see her is?
It depends. Right now, not much. I could
what's
probably get you scheduled for a psych eval next week if you wanted one. And then once you're in, she does typically monthly med reviews. Her services are all mental health, or not mental health, are all telehealth unless someone desires to be in the office. A 20-minute med review, we've realized people much prefer to be over telehealth than to spend 20 minutes coming to the office, have a 20-minute session, and then leaving. So that's been really helpful for her to be able to do that. So wait time for her, it depends on our 20 clinicians. We have a lot more clients, we have a longer wait time. We have 5 clinicians, we have less clients, we have a shorter wait time for her.
So could someone be coming to you just for psychiatric services?
Not starting just with psychiatric services. We believe in therapy and psych services, so we have people that are involved with us for psych services only, but they've been a client with us already. They've completed all their treatment plan goals, and they just need the psych services to kind of maintain. And again, treatment's fluid, so we have times where Emily will be like, hey, I met with so-and-so today, they need to come back into therapy. So they'll come right back in too.
Got it, great. Another question is your IOP, is that specifically for primary SUD, or do you have anything just for mental health strictly without SUD?
We do. Yes, so we have 2 groups that we run. So treatment in general, individual treatment can be primary mental health. And then we have 2 groups. We have a women's empowerment group that it has little bits, but we've tried to make it pretty solely mental health focused. And then we have a perspectives group, which is a thought-based CBT group that's mental health focused.
Great, and besides that, do you have another one that's primary SUD, or those are the
Yep.
2 groups?
Nope, we have more groups. We have exploration. Took me a while. It was gone for a minute. We have a group we call exploration. So that's are like pre-contemplation, contemplation, education type substance abuse group, where people maybe not sure about recovery, not sure if they really want to make change, so just try to get them education on why they might want to make a change. So that's exploration. And then we have journey, which is people further along in their recovery journey. So that's a lot more support, kind of higher level than our exploration group. And then we have evening or daytime recovery, depending on when we're running it, is what we call it, which is kind of a combination of both. Legislation has changed, but it used to be that social workers could only see Medicare. Social workers were the only people that only licensure that could see Medicare. So we would have Medicare clients that that maybe our group was being run by a counselor. So we made a group that was specifically that like Medicare clients could come to. And so it's kind of a combination of our exploration and our journey group.
Great. I have some more questions about the modalities you guys use, but I think we're late on time, so maybe I'll ask you later.
Yara, thank you very much. Anything else? Yes.
Can you hear me okay?
Yeah.
Okay. So hi, everybody. I'm Charlie. I'm new.
Charlie.
I'm one of the politicians that was mentioned earlier. So I was just wondering, I don't see numbers of how many folks are in day one or PRISM. Did I miss that, or do you have a rough number?
I could probably think of a rough number. Because it's fluid and always changing, don't have like a today number. But I would say currently around 300 to 400 clients.
In day one?
Yes.
And PRISM, or day one?
I would say in both. Do you know how many are
Yeah,
in PRISM?
PRISM, there's like 35 right now that we have just for that specific group. But,
okay, thanks. And then of that, what percentage or number, again, rough numbers, are on that sliding scale you mentioned, at least for day one? It sounds like maybe
very few are on our sliding scale. We just ran it for a grant, and I think it's like 3.
Okay, cool. And
it used to be a lot more, like 10 years ago, but with Medicaid expansion, that changed a lot of things, so a lot more people have insurance. So we're able to see more people because of that.
Cool. This is kind of a theory question. So I see in here you talk about abstinence, right, in like use. I've read somewhere that isn't like the done thing everywhere. So is there any thought to that, or why is
we are more person-centered than abstinence-based.
Okay.
So we have clients that want to go down a harm reduction route, so we will do that. We have clients that want to be abstinence. We'll make a relapse prevention plan. With a harm reduction client, we'll make a harm reduction plan. How will you know when your use becomes problematic? So it's very person-centered, and in this field, there shouldn't be, in my opinion, a lot of cookie-cutterness in it. So it's, what is the client looking for? Some things, like, it's working to steer them in a certain direction also, that how can you casually use opiates? Like, not usually well, so how can we kind of mold that to change that?
Understood. Okay, thank you. And then last question was, and this might be a OCHN question for the budget, but just trying to learn the budget. Where would we find you all on this?
I think that'll probably be a great question for when finance comes up, but I do want to at least share on this point in terms of the budget, especially for our women's specialty services. We receive very specific funding from MDHHS for our women's specialty services. So it is dollars that are specifically carved out of Medicaid that are for our women's specialty. So I can't speak specifically where the line item is on the budget, but we do receive very specific funding from the state for our outpatient women's specialty services, and then we also, with another provider, have withdrawal management and residential women's specialty services as well.
Thanks.
All right, let's thank our presenters and move on to Sarah with updates from the committee of the whole.
Just going to pull up my notes really quick. Okay, so currently the staff at OCHN is working on the Quality Assessment Performance Improvement Plan, also known as a QAPIP. It's due today, and then they're going to be presenting it to us next month. And then another thing that we went over is that we're working on appointing another person to the Recipients' Rights Committee, and then the Needs Assessment Planning. So that is out and available. Everybody should be taking it. It just assesses the needs within the community, so you can take it as just a community member, a support person, someone who's involved in providing services, or caregiver. I mean, I took it a few times, once as a board member, once as a community member, and once as a caregiver for somebody who uses services. And the more surveys we can gather from the community, the better we can adjust the budget and provide for what people want and need in our community. Actually, I'm making people take it at my work. I work at a bar, and I'm just like, here, take this. And let's see what else we went over. Oh, that is about it for the COW. It's pretty short this month.
Thank you, Sarah. All right, let's move on to the quarterly financial update from Cheryl. Patrick and Nian.
Good afternoon. We're going to be providing the first quarter update for the SUD quarter one FY24 budget to actual. And I have with me Nian Bland. She's going to be help facilitating and going through the report that's on their screen. And we'll provide all the information that we have available to you for this report.
Thank you. There we go. Thank you, board members. My name is Nan Bland, and I have been charged to come on board and take over carry on Ling Lee's responsibilities in regards to SUD. So first, I'd like to ask everyone to offer me a little grace in a short time period to pull all this together. If I'm not able to answer questions. Oh, thank you. Perfect. Okay, thank you. Can you guys hear me now? A little bit better? A little bit better? There we go. I think that's better? Okay. Afford me just some grace as I pull things together. If you've got questions and I'm not able to address them, I'll do my due diligence and follow up, okay, within a reasonable amount of time. That being said, I'd like to thank, I believe it's Dawn, for being able to pull together. I think you guys have a handout, okay, for the late submission. And I'm just going to go through, I won't read this, but I'm just going to go through some notables before I get into some talking points, okay? So in this grid here of our financials, I want you to note that in the revenue section, the total, the total revenue budgeted is based off of our fiscal year 2023 budgeted numbers, and our monthly amounts is a straight line allocation of those numbers over 12 months, okay? When we get into our expenditures, that is our actual amount here, and they are annualized for the full year projection of our first quarter, okay? And then, of course, in the last section, that's going to show our fund sources by, by our financial position for each line. Sounds good? So I'm going to kind of talk those down. Any questions with that? Don't think so? We're good? We'll keep going. For the general fund and the block grant, the October and December budgeted revenue is approximately $813,000. The expenditures is $888,000 with a deficit of $75,000. The revenue payment is received upon quarterly E-grams FSR submissions. Therefore, the deficit for October and December through December will be covered. However, the fiscal year 24 full year projection will show a deficit for approximately $300,000. OCHN may submit a request for additional general fund and block grant funding in the final amendment to Michigan Department of Human Health Services, and that's due May 15th. So we do have up until that date if we're going to make an adjustment or an additional submission. Adjustment and amendment, thank you. And that's May 15th. If the budget amendment is not approved, we will be using PA2 to cover this deficit, as we did historically in the past due to budget decreases from the department. We're good on that? Great. I'll keep going.
I'm sorry.
Sure.
I do have a question. Who makes the decision if we submit an amendment or not for that one? If something's due by May 15th, who makes
If we're going to request more block grant funds,
That is correct.
typically that's going to come from finance, and they also talk to me about where we're at with services. But every year, we always ask the state for more block grant services because we are historically underfunded. So
Correct.
every single year, we do make the request. On rare occasion in past years, we have gotten a little extra money, but it's not always guaranteed, as you know.
Yep, thank you.
Mm-hmm.
Shelley?
So the PA2 money could supplement your budget, is that correct?
That is correct.
Can the PA2 money also, for those of people who don't know, PA2 is that tobacco and alcohol stuff we get, okay, annually. Can it also supplement any budget, like mental health budget, or no?
No,
'Cause
not without oversight board approval.
Okay, so this board has to approve the PA2 money going to mental health rather than substance use.
That's correct.
So just so I can interject, when it comes to the use of PA2 dollars can only be used for SUD services. So
Right.
if there is a shift in funding, if PA2 dollars are used, it would be to supplement other funding sources, such as if we were paying for something out of block grant or Medicaid, the ask would come to the board to utilize PA2 instead, because those PA2 funds can only be used for SUD, and then the Medicaid dollars would be shifted to the mental health. So PA2 can only be used for SUD. Other funding sources with more strict restrictions can be shifted to other funding sources.
Okay, thank you.
Mm-hmm.
So it's a relief fund for a reallocation, basically, is that what you were saying, if that's approved? Okay. Thank you. Thank you. Okay, moving to Medicaid, and I'd like to note that this does include the women's specialty services in these numbers that I'm going to read off now. For the Medicaid October through December, budgeted revenue is approximately $1.4 million, and the expenditures is $883,000 with a surplus of $569,000. The full year projection shows the Medicaid surplus of $2.2 million. We will be redirecting the surplus from Medicaid to cover the deficit in Healthy Michigan expenses as we move along throughout the year, okay? Any questions to that? Great, we'll keep going. For Healthy Michigan, and this also includes the line item for women's specialty services, okay? Healthy Michigan, October through December budget, revenue is approximately $2.3 million, and the expenditures is $1.7 million with a surplus of $617,000. The 4-year annualized projection shows a surplus of $2.4 million. However, the initial budget reflects a deficit of $276,000, which we'll cover with the Medicaid surplus if we continue at this rate. Okay. I'll keep going if there's no questions.
I don't see where the 276 in deficit is.
And that is not reported in the information that you have here. It would have been a separate document that I believe was previously, and correct me if I'm wrong, previously reviewed with this board. Future, I will have that document readily available for you to at a glance. Sound good? Great. Prevention. Prevention October-December budgeted revenue is approximately $274,000, and the expenditures is $511,000 with a deficit of $237,000. The revenue payment is received upon quarterly e-gram submission, therefore the deficit would be covered. However, the fiscal year 2024 full-year projection shows a deficit of $950,000 again. We may submit a request for additional prevention funding in the final amendment to Michigan Department of Human and Health Services. That's due by May 15th as well. If the budget amendment is not approved, we will be using PA2 funds to cover the deficit as we did historically in the past with the budget decrease. Any questions?
I'm just curious, do we have a department that just basically writes grants?
So we do have here, we have Frances Carley, who is our strategic planner who oversees all of our strategic planning, and she also has a grant coordinator under her as well. And that grant coordinator for all of OCHN, they are always out looking for different grants and different funding sources we're able to utilize. Within the SUD department, we also have our own grant coordinator, and when it comes to the grants that we receive, block grants, even though it's called block grant, it's not, I'm doing air quotes, it's not a typical grant, if you will. It is just the name of our funding stream. It's funding that we've always received. It's just the name that they have given to it, so it's not, when you think of a grant that we have to write for and all the work that goes into grant writing, that doesn't happen with these block grant dollars. And then when it comes to our other grant funding that we have, our COVID supplemental funds, our CSUGs, our ARPA, the American Rescue Plan funds, the state opioid response, the SOAR funds, those are pushed through from the state. So we do not have to write the grant in the SUD department. It is the state who is actually the middle person, who does the grant writing, who oversees it, and they push the funding down to us.
All right, I'm going to ask that the board hold questions to the end so we can continue through without pauses. So no need to stop in between each line item.
Sounds good. Thank you. Continuing to the SOAR grant, October through December, the budget revenue is approximately $583,000, and the expenditures is $259,000, with a surplus of approximately $324,000. The revenue payment is received upon quarterly eGrams FSR submission. The fiscal year 24 full year projection will show a surplus for $1.2 million. PA2, this October through December budgeted revenue is approximately $1.2 million. The expenditures is $235,000 with a surplus of approximately $1 million. The 4-year projection will show a surplus of $4 million. The PA2 balance update, okay? So I'm going to give this in just one number, and I know I have some homework to bring back to the board. We are currently at $22,656,096 as of December 31st, 2023, okay? And that's with all considerations as of February 7th. that came to me at the last minute, so I will make sure that I've got a hearty report and representation going forward. And then the Healthy Michigan funding information. There was I believe, an action item from the last board meeting asking for specifics about the funding, where it comes from, more information regarding how it is to be used, those type of questions, concerns to be addressed. This fell off the radar, so here's what I grabbed. I apologize. The Healthy Michigan Plan is a plan that meets the requirements set forth by the Affordable Care Act. It provides the 10 essential health benefits identified in the Affordable Care Act, plus specialty behavior health services. As a result, the benefits in the Healthy Michigan Plan have a broader range of services, especially in the specialty behavior health area, than traditional Medicaid. It is a Medicaid program through the Michigan Department of Health and Human Services, and then on a 50,000 feet level, 71% of the $33.4 billion Department of Health and Human Services budget is funded by federal revenue, including Medicaid and Healthy Michigan Plan matching funds, food assistance funds, and the TANF block grant. That's basically the overall information I'm able to bring to the board today. I'll go ahead and do some due diligence and have a more hearty, robust response at the next meeting.
Well, thank you for pulling together at the last minute. Now, any questions? Shelley?
Okay, I always love to see the PA $2 spent right here, rather than a shift in a shaft and shove the Medicaid dollars. So do we have waiting lists for services?
No, we do not right now.
Okay.
We are not, the state guidelines are that our providers, depending upon a person's priority population status, the longest wait per the state guidelines is no more than 14 days after the initial request, and we are staying within those guidelines. And we know that because all of our providers within their contract, should they have to start a wait list, should they exceed that 14 days every single month, they need to submit to our department then what their wait list is, how many individuals. So we receive monthly reports from our providers if there would be a wait list. So that's how we know there is not right now.
Okay, is there some other way we can spend our funding rather than shovel it over to the other board because they can't manage their budget? Just asking.
So I think when it comes to our funding, absolutely, you know, Shelley, we're always looking at what are the new innovative programs. That's really what we use the PA $2 for a lot. We have our Medicaid dollars, we have our block grant dollars. It's those dollars for Medicaid and block grant. There are very specific rules over how we're allowed to spend them, what we're allowed to spend them on. And so really that's where the ARPA, the CSUGs, the SOAR, the PA2, that's where we're able to do those more innovative programs. The Sober Support Unit, that's one of the programs that started under Christina Wish, that when she was here that I absolutely love because it allows people to access the services. So no, we are always actively looking at what do we need. During this past 2 years, especially with CSUGs and ARPA, we've seen an increase for SUD grant funds. So we have been looking at what can we do to utilize those funding sources to try to free up our block grant and Medicaid dollars. And so, no, we are going to look at, I'm actually going to be going to a national-wide conference at the end of this month, so that way we're able to see what is out there, what is new, what is innovative, and what can we bring back here. So don't worry, I'll bring us plenty of ideas.
Good. Thank you.
All right, anything else? Charlie?
Thanks. This actually might be kind of what Shelley's question was, so help me if I'm getting this wrong, trying to understand this. But with the $9.4, almost $9.5 million we'll see in surplus for this section of OCHN as a whole over the course of a year, Shelley, was this kind of what you were asking? How do we keep that money here for these programs?
Oh, yeah, because what happens is we get the PA $2 from the alcohol and tobacco stuff, and we use that to fund ourselves on this particular board, okay? And then the extra Medicaid money that we have, because mental health is always running in arrears, not always, but sometimes. we have to funnel it to them to save their butt, pardon my language. But anyway, so my question is, why can't we keep it in here, you know, so that if we have waiting lists, if we have people in need, if someone needs something like housing, if we can't, why can't we supply it for those who have substance use disabilities and such, as opposed to giving it away to the other team? That's my hope. Or could we get, you know, I don't know, housing for people who are on the streets, all of whom have substance use difficulties. I don't think there's anyone on the street who doesn't. Maybe I'm being too generalized, but I think I'm right. So that's what I'm talking about. How could we use that money to help people who really need it, who have substance use problems? That's it.
Okay. And then what your response was that some of it is, like locked into certain things.
Some of it's locked into certain things. When it comes to the PA $2, there have been times in the past where previous CFOs have come to the Oversight Policy Board, have asked to move around funding sources because of deficits. And I know how some on the Oversight Policy Board feel with it seeming like a mental health side and an SUD side. We really do view OCHN as one. And I think with what has, occurred in the past with having to look at utilizing PA $2 to cover deficits, that has occurred under past administration and past leadership, and I don't think the new executive leadership we have with Dana and Cheryl and Patrick, I don't think that is not their intent of how they want business to operate moving forward. That should really be the absolute last resort. We have no option. We're in DEFCON 5. And so when it comes to our funds and what we have, a lot of times the funds, they are going to kind of stay with us where they can. And I don't want to speak for finance, but I'm going to venture to say our numbers shift so much with our eligibles, the dollars that we're receiving, where we initially might project out $25 million for the year, but based on how many people are eligible, that can shift our dollar amount of what we actually receive for the year. So that's where really year end, when everything gets reconciled, we can project out, we can think we're going to have $9 million more, but then at the end of the year, we really find out, are we breaking even, are we not? We do try to keep everything within, for SUD, that we absolutely can, of what's new, what can we do. That's how we just did the rate increases for our outpatient and MAT. So we looked at what are we projecting to have for this surplus, if you will, in this fiscal year. And we hadn't done rate increases since before the pandemic. And so we had done that with the RFP we had done. So yes, we want to use as much as we can for SUD, but we're going to see, I think we're always going to see a shift in our financial numbers till we really get to that year end to find out what's that dollar amount we're over. I think every year for SUD, we're really coming in right at our budget. We are typically not over. We are typically underfunded by the state. That's always a conversation point we're having with the state. One of the conversations we're having now with the state is, with the state receiving opioid settlement dollars, is that something they can push to the PIHPs to account for the fact that we are historically underfunded, which is why we historically then have to dip into our PA2. And every year we come to the board and we say, hey, here's how much dollars that we expect to spend in PA2 because we are being underfunded. And the other option that occurs at other PIHPs, and I'm thrilled and happy it doesn't occur here with us, across the state, when they run into funding issues or if they won't approve the use of PA2 dollars, wait lists will occur and services will be cut. And our philosophy here is that's our last resort of what we ever want to do, and the board has always been incredibly supportive of that. So the PA2 dollars have always been approved and been able to have been utilized, so we have never had to go that route yet.
Thank you.
All right, anything else? Colleen?
So I tried to find out on my own, what does CSUGs mean?
CSUGS means, COVID supplemental,
Oh.
COVID, substance use, gambling, epidemiology. I know I'm not saying it all correctly, forgive me. Essentially, it's our COVID block grant dollars. I was close, forgive me. We call it CSUGS for short.
Okay, anything else? All right, let's move on to legislative updates from Christine.
Good afternoon, everyone. Christine Burke, Chief of Staff. I think I know most of you. Out of consideration for time, I've chosen 3 topics for today. In your packet, you received the FY25 executive budget proposal for the governor. This is high level and only pertains to those matters that are affiliated with the public mental health system. So the Community Mental Health Association of Michigan and then Capital Services, who is our legislative consultant, will review the governor's budget proposal, give us a high-level summary, and then what we do on our end is go back and look at the details of the language, doing our due diligence to determine, is the language written in a way that would prohibit us from receiving funding as part of the budget? Are there areas we can make recommendations? Because it is a proposed budget, and we do this almost every year, after we review it, we might say, for example, this line says only organizations that have a grant from this organization through this time period will be eligible for this funding. Then we would go back and say, well, taking into consideration we have experience here, here, and here, we would like that language stricken from the budget. Or we offer input that says, can you include language that says we're a PIHP? So we are in the process right now of vetting the budget to determine those areas where we want to make recommendations, and those recommendations will go forward. Usually for one of our local legislators will take up the issue on our behalf. And this budget, specifically in the highlights, like 3 areas I would want to bring to your attention. There is a line that talks about recovering coaching, so we're going to have to find out how does that impact our organization. Is that funding going to facilitate through to OCHN? There is another section that talks about services for individual in incarceration. Again, we'll review to say, is there avenues for the language for funding to come to OCHN and to our service system? I think there are 2, but the one that I noticed was a topic of concern yesterday in Lansing, and we've been talking about too. Workforce shortage, sustainability is a concern unintentionally, and this happens all the time. Language is built, okay, we're going to shore up and we're going to really strengthen mental health services in our school system. Absolutely necessary. But what happens sometimes in some of that language is it puts us in a situation where, as an employer, where we were competing with the private health plans, we can't. We are public, they're private, and we don't want to be in those same situations with our school systems. We want to strengthen our mental health services within the school and their ability to hire qualified professionals, and at the same time, keep the public mental health system strong. So that is a conversation, that dialogue is ongoing. Some of the suggestions they're looking at, too, in terms of recruitment is providing internships, paid internships, supplemental pay for people for student loans. So one of the really significant challenges when we talk about capacity to serve is staffing, not necessarily beds, as people will say that. It's really level of need. So you may have one person, but he or she may need 3 people for assistance. And so if you have 3 or 2 beds or whatever going on in that area, but the one individual is there and we only have enough staffing for that one individual. So when we talk about the staffing crisis, really what we are also looking at is level of care, and then how do you recruit people to want to do this work? It takes a very unique person with a set of compassions and desires. So understanding and better understanding, what does Gen Z want? And how do we bring them into this field to keep the legacy of the public mental health system moving forward? That's what we're working on now. I expect the budget, from all things I'm hearing, it's an election year, budget's going to be shored up by the end of May. and people are going to start campaigning. Last year, we were on time. Conversations started in January for most organizations, us included, areas in which we would ask for funding specifically included in the budget. So that dialogue is happening. Dana, we are actively engaged with our legislators all year long. We have 2 events where we bring them in to do a presentation, ongoing education. Traditionally, between January and May, Dana will schedule a number of meetings with legislators to talk about very specific challenges and issues within our system, and then helping them to understand the unique challenges to the public mental health system and those different nuances that occur every year. What may be a challenge in 2024 may not exist in 2025. So it is always a moving target in making sure people understand the depth of our specialty services, our value in the community, and how and why our funding is so critical to Oakland County and to the state, and then really understanding the complexity of what we would call our service buckets. I call them service categories. So, any questions on the budget? I apologize for putting this in your packets last minute. I actually just received it, and I think it's really important information. I did not want to miss the opportunity for you to have this information. One of the conversations that we continue to talk about is the Medicaid eligibility. Early on, and when the public health emergency started, some of us would say it is going to be easier to move into the public health emergency than it is going to be moving out of it. So when the public health emergency happened, Medicaid eligibility increased. That meant our funding increased. As an organization, we made a commitment to push out everything we had into the community to help us through the crisis. So one example I like to use is we did get a call a couple days before the state shut down that basically said, state's going to shut down. When we have congregated settings, we needed to make sure our crisis response plan was in place. Even before the state shut down, we were already buying PPE for our service sites. We have 400 service sites in the county. We serve 29,000 people. We began purchasing the PPE, had it delivered here, just separated it by piles, and then we had volunteer staff that on a weekly basis for 3 months would come to our organization, pick up delivery, and all volunteer, pick up their delivery, and then our staff would deliver PPE to all 400 service sites to make sure that people had masks, gowns, gloves. Back then, dial soap was considered PPE. So those are the types of things we did moving in. As we are moving out, the concern about eligibility decreasing is ongoing. It is not unique to Oakland County. It's not unique to the state of Michigan, and it's not unique nationally. The increase in mental health services that happened during the public health emergency, the increase in need is not decreasing. Eligibility is decreasing. Some things that are very, very specific to understanding, besides enrollment, we have a team whose goal it is, they have a work plan, they've been doing this since July. Persons whose eligibility may be coming up, they will get a letter from the state that says, hey, you need to renew, your eligibility's up. They will get a letter from a provider that says, hey, your eligibility, and then we send a letter that says, don't ignore the other 2 letters and people are going to call you. Don't let this happen. While that in itself an effort is very robust, an unexpected shift that we are talking to legislators about is when people are re-enrolling, they are not necessarily re-enrolling in the same program. So if you look on the back, there's a side here that talks about this. We have what we call disabled, aged, and blind, and then there's the TANF, the Temporary Assistance for Needy Families, and then of course Healthy Michigan. On that document, it shows the funding that goes with each one of those categories. So if an individual, say, was under a DAB category prior to the public health emergency, whatever's going on in the shift change, we will see sometimes someone who is in that DAB category has been shifted to a TANF. We then have to call and say, how did that happen? Because, if you're blind, if you're aged, or if you're deaf, that didn't change. So TANF probably isn't the right category, right? If a family was in TANF, now they're in Healthy Michigan. So there is a significant conversation going on right now. How do we ensure that the public health system stays whole and healthy as we navigate out of this Medicaid public health emergency? How do we make sure that services stay in place? And then how do we ensure that people and families especially are not shifted to a different category where they're not going to get the full array of services or the funding isn't associated with it. So that is why I put this in last minute. We just received this document, and this is a priority conversation that I know Dana is having with all of our state legislators. That's what I have. Any questions?
Oh, Charlie?
I mean, I guess a question is there any way we can help with this? Because it sounds terrible.
It is a significant challenge, and like I said, it's not just with the county. I do think the department is doing their very best to enroll people. They are actively involved. There are just those unique challenges that as we move out of a public health emergency, it is uncharted territory for us all. So I think the ongoing conversation in terms of appropriate funding and recognizing if the public health emergency, well, it brought many things to light. It also brought to light that there is an increased need for mental health. People weren't as afraid, stigma was reduced, that it may have really changed the trajectory in the way people seek health and public health. And if that's the case, we have to make sure the appropriate funding is there as well. And really just being aware of the information I'm hoping will help you have informed conversations with legislators about the dialogue we're having and all of the PHPs most of our providers are having in terms of how do we then meet the need with a decreasing budget based on eligibility.
All right, thank you. Community outreach updates from Caitlin.
Actually, it's Suzanne. Caitlin was going to pinch hit for me, but I'm able to attend. So, sorry about that. Suzanne Weiner, communications team. And similar to the other board, you can go ahead and do the next slide. Similar to the other board, we do communication update of our outreach and awareness efforts in the community. So we thought we would do the same for this board. But rest assured, I just do highlights, so I'll be brief. As you can see, we've had staff at a number of career fairs, so this is an opportunity for us to recruit new talent. Additionally, we have had staff at a number of conferences, which is an opportunity for some staff enrichment and learning opportunities. I do want to bring your attention to our annual Call to Charity. It actually is going to be a couple times a year that we're hosting this event. We had that event earlier this month, and we had over 100 participants at the event. It was an opportunity for some great conversation, enriching conversation about mental health services, substance use disorder services, social determinants of health, as well as homelessness. So we're geared up to host another event in October related to our Call to Solidarity efforts. Next slide, please. Also wanted to mention we are hosting almost monthly or quarterly, sporadically, I guess I should say, is our SUD community workshops. We just had one earlier this month related to post-traumatic stress disorder for our vets. You'll be hearing a little bit more about some of these ongoing efforts. Sherry's going to provide some information about some of our upcoming workshops related to substance use disorders. We're also hosting next week it's an annual Abilities Awareness event. It's for Disabilities Awareness Month, as well as launching our Community Behavioral Threat Assessment and Management Initiative, and that is going to be happening in a couple of weeks. So lots of planning, working with our legislators and working with our community partners to promote that event. Next slide. Also wanted to bring your attention to the press releases that are put out. And actually, typically, we put out on average between 4 to 6 press releases per month. Hopefully, you're receiving them. If you're not, we'll make sure that you're on the list. They are posted on Boardable, but as you can see, highlighting different awarenesses during the month. Obviously, Black History Month. You already learned about our service delivery feedback survey. I'm going to give you a little more information about that as well as some behavioral health training we held for the FBI and some mental health tips. That was actually following the verdict of Jennifer Crumley, which led us to a couple media opportunities to get the message out about behavioral health services. Christine kind of already mentioned the redetermination efforts, and we usually give our boards an ongoing update of the ongoing efforts. She mentioned the efforts that we're doing with the letters and our social media efforts in terms of Medicaid redetermination. Also, our facility here is a multifunctional facility, so we usually like to update the board to let them know use of the facility. So Community Housing Network is actually a tenant, but they use our space quite often. Life Skills is one of our vocational providers, and they use it as well. But other partners, the Health Division for other events, and other partners use this facility too. So we like to give that update to the board as well. Next slide. And last, Ms. May was nice enough to plug our service delivery feedback survey. You have this flyer in your packet as well. The QR code is right there. If you'd like to fill it out, you can fill it out. But this is an opportunity for us to get feedback and develop our fiscal year 25 plan. So it's really important that we get that feedback. We're distributing it widely. We're actually going to a number of substance use disorder residential facilities. I will be at one of them tomorrow morning. And we go out and we bring actual hard copies of the survey for individuals that are served, and we help them walk through the survey so that we can get those surveys, those hard concrete surveys right then and there. We do it at our clubhouses, some of our drop-in centers, and as I mentioned, we are also doing it at some of our SUD residential facilities. And that is all I have. Does anyone have any questions for me?
All right, thank you.
Thank you.
All right, now we have Megan with the director's report.
Thank you, Kelly. So a couple things that I just want to hit on. Coming in the next 2 months or so, we have the RISE Center. The RISE Center is a drop-in and support center that helps provide adjunct services for those people that are working towards recovery. It is a service that is available to the entire public. So the location of the RISE Center is at the Resource and Crisis Center, in the Oakland County Plaza. And historically, since the RISE Center has opened, it has been staffed by and it has been run by one of our contracted providers. And so in these coming months, we are going to be bringing that service in-house. So Personalized Nursing Lighthouse, they have been nothing but a fantastic partner in this entire venture with the RISE Center. They are our provider from day one. They helped launch and create this, and they have built it into what it has become today. And really, essentially, the only reason we are looking to bring it in-house is once the pandemic has occurred, once we are coming out of the pandemic, the issues that we are seeing with the workforce, the issues our providers are seeing with the workforce, it's challenging for that provider to keep it staffed when the primary location for that provider is located over in Plymouth, and then also other locations in Dearborn and Madison Heights. So when somebody calls off from the RISE Center, it can be very challenging for them to still have staffing for it in that same day. So we're going to bring it in-house. It's also more cost-effective for us to bring it in-house. So we will be doing that. It will sit underneath our Access Center. And what makes that a little more ideal at our Access Center, the Access staff right now probably has a staff of well over 40. Now, all 40 people are not at the Resource and Crisis Center at one time working, but when somebody calls off, when there's a sudden influx of need for people seeking the RISE Center services, there is a lot more Access staff that's readily available and able to fill in to meet the need of the public. So we do want to say a wonderful thank you to PNLH for all their years that they have done with working in there, and we expect for around April or May for that service to have been hired in-house. The next piece that I'm going to cover is I'm going to do a brief overview of our CSUG's grant funds. The last time we met, I had gone over the State Opioid Response Grant, so our SOAR funding and what projects we do under it. So this time I had wanted to talk and go over our CSUG's grant. Now our CSUG's grant This funding will be ending this March. We have had this funding, forgive me, for at least about the past 2 years, 3 years, 2 or 3 years. Forgive me, I could not tell you without looking at my notes offhand. But the programs that we do under our grants, what make it just important for everyone to know, and it's kind of what I was hitting on earlier as well, our block grant dollars, our Medicaid dollars, that's really what we're using for our treatment services, our prevention services, and the standard array of services. So our outpatient, intensive outpatient, withdrawal management, recovery housing, that is how those funds are being used. It is our state opioid response grants, our CSUGs, our ARPA. These are the funds that allow us to get a little more creative with the programs and services that we are able to offer to the community, as well as our treatment network. So some of the things that we've done under treatment while we've had these CSUGs grants is we've been able to provide our treatment providers each with $25,000 for training funds that they have been able to use at their discretion to say is it that they need to train their network in seeking safety or train their staff in seeking safety? Is it that for McBAP credentials? In order for someone to receive peer recovery coach credentials, CAADC, the Certified Advanced Alcohol and Addiction Drug Counselor credentials for McBAP, it takes a significant amount of CEUs, which cost dollars, as well as taking the test, as well as supervision. So these funds that we gave the providers, this is all funding that they could put towards their staff to help alleviate those costs. Also with the intention then, as we are struggling, everyone, whether it's OCHN or our provider network, as they struggle with the workforce issues, it's a way that we're able to kind of help give back, help our network try to sustain, try to remain whole, and do that. So we were able to provide that. We also provided some network-wide trainings by working with our training department here at OCHN. We also have pilots that are coming down the pike from the state, one of them being a recovery incentives pilot, which is essentially doing contingency management with individuals. We've known for over a year that this pilot was going to be coming from the state, so because of that, we used some of the CSUGs fund to train our entire network in contingency management, so that way they would be able to participate in this pilot should they choose to do so. Also under CSUGs, that is how we are funding the SUD health home, the opioid health home that is funded under our Medicaid dollars, but our SUD health home, which is anybody with an opioid use disorder who does not have Medicaid, or anyone with any other substance disorder, that is not covered under the Medicaid dollars. So it's only those with Medicaid with an opioid use disorder that the OHH is covered under Medicaid. So our CSUGs is covering the SUD health home portion of it. We also had the ability, this came down last summer, we had provider stabilization payments. So with the pandemic, with the financial impact that it had on our provider network, we were able to put out to our provider network and ask who is in need of financial assistance due to the pandemic, due to the hardship that it costs with lost staff or being able to still operate a business when we were in shutdown. So we have funds that are going to be able to go to our providers who made that request. We also have technology upgrades that we did. So with the advancement, obviously, with telehealth, we were able to offer to our provider network and say to them, in order for your organization to be able to provide telehealth services seamlessly with ease, what is it that everyone needs? Is it laptops? Is it dual screens? What is your need exactly to provide those telehealth services? So everyone submitted a proposal to us, we reviewed it, and we were able to supply $130,000 across our treatment network to ensure all of our providers had the capability and everything they needed to provide the telehealth services. The one thing that we have under prevention with CSUGs, we have our justice expert liaison, and so what that is we have an individual who is embedded over at the Oakland County Prosecutor's Office, and what they do is they work with individuals who could be facing charges. They're doing expert screenings, which are screening brief intervention surveys to identify, is there a substance use disorder, is there a mental health disorder, is there a treatment need? Essentially, the entire goal is to look at, can a person be diverted from the criminal justice system? So that is what we have used our CSUGS funding for. I do just want to point out, so that way if you look back at your sheet that you received 3 months ago, you will see anytime that we go over one of these sheets or we give you one of these sheets, these numbers are always going to change. So don't be surprised by that. If you compare this to the sheet last time, one of the things that happens with our grant funds that I think I had hit on a little bit last time was we have the ability, when we have been granted our entire dollar amount by MDHHS, programs can shift at times. So we can have one program where all of a sudden we're having problems, we can't get it lifted up or started, or we're working through issues. But then we have another project that comes up we could shift the funding to or create a new project. So many times throughout the year, we have the ability with the state 4 times a year to shift our funding around all of our line items for our grants. So I say all of that because these are line items, you will never see them typically stay the same too often. So I just always like to explain that because there's a lot that goes into it. We are meeting typically bi-weekly between finance and the SUD team to talk about our projects. Where are we at? How does funding have to be moved within the EGRAM system, which is the grant reporting system within the state. And with that, I will end there. I will save ARPA for the next time we meet. Do we have any questions? All right, thank you. Oh, yes, Charlie. Or sorry, Commissioner Cavell.
I don't know if you're like pretense about the money moving around, but I circled here the unallocated.
Yes.
Can you explain that?
Yep, so when it comes to our unallocated dollars, sometimes with what can happen, and I actually don't have it on here, so thank you for pointing it out. Sometimes when we make plans, we might have a project that we say costs $350,000. As we start to move through that project, we can encounter problems, things we didn't anticipate where we say, you know what, we're not going to move forward with the project anymore. We can't for whatever reason it is. I'm never one nor a fan who likes to just go, oh, extra money, we're going to just give it back. That's not how we like to do things at all. So currently on here, the unallocated dollars, and I should have had it updated on here before, but I didn't. The unallocated dollars are actually funding and dollars that we are using for campaigns, and we have shifted for a communications budget. So we have that funding that has been moved to work on SUD-specific campaigns that will be done on different news stations, as well as bus ads and billboards. So that money is not unallocated any longer, even though it says it on there, so my apologies.
All right, let's move to treatment updates from Sherry.
Good afternoon, everyone. I'm going to make this really, really quick. In terms of the Recovery Incentive Pilot, it is a MDHHS initiative to implement contingency management services, which is an evidence-based practice that focuses on providing incentives to individuals served for their progress in treatment and in their recovery journey. We will be launching the pilot October 1st. We have 4 providers who are interested, and we are awaiting more guidance from MDHHS. So we're very excited about our initiative. Any questions?
So that's in next year's budget, correct?
Yes.
Okay, thank you.
Correct. The next item, just really quickly, contract conversion. Contract conversion is the SUD team aligning the framework of our contract with all the other contracts that OCHN has. So the framework for our contract is a little bit different. So we are making changes to align with the other business practices of the organization. The contract requirements are not changing. What is changing is the framework, document titles, where they're located, etc. This has been a huge undertaking, and it has required our collaboration with several OCHN departments and teams, and I'm pleased to say that we are almost there. Once we complete the project, we will let you guys know. Again, contract information and requirements are not changing, just the framework of the contract. Any questions? Also, as Suzanne Weiner mentioned earlier, in your packet, you have information about our SUD community resource events. Our next community workshop is going to be April 11th. You have this in your packet, and then the one after that is in May. You also have the entire schedule for the rest of the year and our second annual community baby shower, in which we are very, very excited about. Any questions? Okay, thank you.
All right, on to data review by Bradley Sharp. All right, you guys are throwing me for a couple loops here.
So yeah, unfortunately, Brad was not able to join us, so he will be providing the update moving forward. But you get me today, so yay. All right, I'll keep this quick. But again, all of you have copies in here. You'll be receiving this information quarterly, so you'll be able to kind of track instead of just getting year end. So you'll be able to see how things change throughout the year. So we can go ahead and move to the next slide. So I broke this down just so that it's a little bit easier to read. All of the numbers for those receiving treatment services. So on here, so we see the breakdown. So for quarter one, we're talking about from October to the end of December being our quarter one. So again, for the ambulatory withdrawal management, we've had one individual for that quarter. Again, that's not super common. Our intensive outpatient, we've had 44 individuals, outpatient 176. And for our regular 24-hour withdrawal management, we've had 214. Go ahead and move to the next slide. For our MAT services, we've had 149. Our long-term residential, 33. Short-term residential, we've had 368. And our women's specialty saw 28 individuals for this quarter. So then our sober support unit, again, that is a 24-hour operation. Those are for the individuals who we're trying to hopefully place them into a higher level of care. They're able to stay in a safe spot. Also, it assists with the jail diversions. So over the last quarter, we've seen 339 individuals served. Of those individuals, 298 of them chose to go to treatment. Again, it's their choice, but of that, we've seen a lot of individuals are able to be diverted to an appropriate level of care. As Megan mentioned, the RISE Center, that also allows a lot of different great resources. They're able to help, we've talked about the Medicaid redetermination. They've been able to help people get the applications completed. They've been able to assist with other resources like food, education, all of those things that they may need. So 585 individuals came to the program, and 572 of them were asking for actual resources, tangible things that they can take back with them. With our health homes, under the SUD health home, so again, that's anybody who is a non-opiate user. That encompasses all of them. There was 35 individuals, and those in the opioid health home, there was 272. And again, this is not an actual home. I know the name is misleading for those of you that this is new for, but again, it's that wraparound nursing services, addressing medical, addressing all of those other components outside of just their mental health and or substance use need. And then we are looking at those in the jail. So this is for our in-county numbers. So the in-county numbers are those that are being funded under the state opioid response grant. So we have 36 individuals that were served in the first quarter. Of those individuals, there wasn't anybody who chose Vivitrol as services. 25 used Suboxone, 11 were on methadone. And then we can go ahead and shift. And then for the out-of-county expansion, so the county came to us and under the use of the opioid settlement funds, wanted to ensure that everyone served in Oakland County Jail was receiving the same service. So they asked for us to mimic what we're doing with Oakland County residents, and that's funded under the opioid settlement funds. However, we are overseeing those services. So for out-of-county, we have seen 24 individuals were served. None of them chose Vivitrol for this past quarter. 22 used Suboxone, and 2 were currently on methadone. And the last is just to kind of give you an idea. I know we talked about those who were on maybe the sliding fee scale, as Emily had talked about earlier with her program. So these are the numbers of those that are underinsured or uninsured. We're, again, ensuring that everyone has services and they're not being deterred based upon their insurance. So over the last quarter, 55 individuals were served who were either underinsured, which again could mean that they just have an incredibly high copay that they can't sustain, or they did not have insurance at all. So that's kind of giving you a little bit of an overview. Again, these will be provided quarterly, so you can kind of track what occurs over the year. Any questions?
Yeah, that was wonderful. Thank you. Shelley.
Oh, okay. You said that 24 out-county people were served in the jail.
Correct.
Does this community pay for them, or do you bill the other counties they come from?
So it is coming from the opioid settlement funds, which is coming from the federal lawsuits that occurred from the or the overprescribing of the opiates. So that's a completely separate thing. All of the municipalities that were appropriate, that met the qualifications, received X amount of dollars, and within those municipalities, they determined how they were going to use them. And within that jurisdiction, part of it went to Oakland County Jail to serve those out of county.
But we can serve everyone who is an Oakland County resident.
We serve that under SOAR funds, the State Opioid Response, those who are Oakland County residents. If, say, somebody from Macomb County or Detroit comes into Oakland County Jail, they'll be serviced. However, the payment will come from the opioid settlement funds.
All right.
I think we had one more question.
What was it? Oh,
yeah.
Okay.
Just real quick, I get the energy of the room, I'm sorry. But, thank you. The 55 people that were on the sliding scale are uninsured or underinsured. What is, like, how much do those people cost the system?
It honestly depends on the service. I'll let Megan kind of go look.
Yeah, it would depend on the service, and I would have to probably work with finance to drill down to obtain an exact number. So it depends on if it's medication-assisted treatment, outpatient, or is it a short-term service like withdrawal management or residential. In terms of how and why we do, obviously, because if somebody has any third-party insurance, Blue Cross Blue Shield, I just took a phone call yesterday from someone, Blue Cross Blue Shield, no Medicaid, $1,000 deductible, $3,000 co-insurance, they have to pay $4,000 to go. They can't afford that. And so that is how they then end up coming to us, because we're the public safety net. And so we do step in, we do fund them, we provide them the provider that they go to. They help provide them with the receipts of what we paid for to submit to their insurance company to work on meeting that then deductible and co-insurance, so that way if they were in need of services again, hopefully that can count towards it. I would have to, and I can get back to you for the next time, especially for this quarter, I can work with finance and IT to say, can we get a general number of this past quarter, what was the dollar amount? Yeah.
Okay. Let's move on to with Megan, reconfirmation of a PA2 loan.
Yes, so thank you. This is going to be very quick. Just as a quick history, we had asked for a special Oversight Policy Board meeting where we had met in September. And when that occurred, myself in finance, we had gone over the budget for the fiscal year. I had also explained all of our uses for PA2, what we are using PA2 money for, and part of that was I had discussed a loan we were going to provide to one of our providers, Meridian Health Services. They had submitted a proposal to us. They were expanding their MAT services, and the loan amount was for $222,000 to be paid back over 3 years in equal payments over the 3 years. And I bring this up today because when we had our meeting, we did not have it in this room. This was when we were back here, and we had what was called an owl that was hopefully recording, and it did not. And so it did not record our meeting, and we missed capturing this vote in the meeting minutes. I know that it very much happened, but I wanted it to be put on the record, and we have it in the record so that way when we are issuing the contract and have all of that, we have everything on record for having it occurred. So that is my synopsis of everything that had occurred. If anybody feels as though that is incorrect or if I am misspeaking, please feel free to speak up. If not, we can let the record continue to reflect that.
Okay, so I'm not sure, do we repeat the motion and vote again?
I don't believe that we need to vote again. It was just being able to state on the record, this is what happened.
This is what was approved.
It was a
Okay.
unanimous vote for approval. And so that way we have it on the record to be able to move forward with being able to issue that contract for that provider for the loan.
All right, perfect, on the record.
I have a couple of questions before we do the vote.
We don't need to do the vote.
Okay, cool. Whenever questions are allowed for this, I would like to.
Okay, now?
What is the repayments over 3 years, is there an interest rate to that loan?
There is not an interest rate, and that is why they came to us instead of going to a bank. With the pandemic, with the challenges that our providers can face, being nonprofits, they're not working with the type of money that a for-profit entity that works with. Do they have the ability to absolutely go to a bank and ask for that loan? Yes, and then they are going to have that incredibly high interest that they are paying on instead of putting that money towards their staff or the people served. And so that is then why they came to us. What this specific provider was doing was expanding their medication-assisted treatment capabilities. So the services, it is very specific for all Oakland County individuals. So while some providers, if you look at like a residential provider, they might hold a contract with all 10 PIHPs. This specific contract for this medication-assisted treatment provider, the contract is specifically only with us. And so in order for them to expand their capacity abilities, they came to us asking for a loan. It made better financial sense for them to do that, for it to be a no-interest loan that we were able to provide for them, that they're able to pay back to us then.
Okay. I just want to then say that I find it disconcerting to give these people this money. From my understanding, I know I'm new and ignorant, but the people that run Meridian, the Cotton family, are literally billionaires. So I don't understand
Did you
more.
say Cotton?
Yeah.
That's not their, it's not who runs it.
The people that started it,
Oh, okay.
Meridian Health Plans. So I just.
Oh, not Meridian Health Plan, very different.
Oh,
Not Meridian Health Plan.
Oh, okay, great.
Nope, and that's
Who is
where it
Meridian
gets
then?
So Meridian Health Services, I know, I was
Okay,
like,
cool.
oh, wait a second, I'm like, who is?
I was like, why are you giving an interest-free loan for?
What are we
yeah,
talking
okay,
about?
Great. Who is Meridian Health Services?
So Meridian Health Services, they're one of our contracted providers, nonprofit entity. So
Okay.
everything they do,
Cool.
it is,
Okay.
money goes back into, the business, people serve, so not Meridian
Great.
Health Plan.
Okay, different.
Yep.
Thank you. Never mind. Great move. Awesome. Okay.
Thank you.
All right, on to new business. Do I have a motion to approve the October minutes?
Yes.
Second? All those in favor?
Aye.
Motion passes. Any other issues or announcements from the board? Shelley has a question.
Do we have any bylaws?
Yes, we do.
Could we have a copy of those in our next packet? I'm sorry?
Yeah, we will have a copy for you.
A printed copy,
Yes,
thank you.
a printed copy. We will.
Thank you. I'm sure they are. The Board and I don't get along because,
Believe me.
okay, that would be perfectly fine because of the situation with the same first initial with my husband. And it can't get it, it's got it all screwed up. So, there.
Oh, right. Okay. We'll open up the floor to public comment again. All right, do I get a motion to adjourn?
So moved.
Second?
Yes.
All those in favor?
Aye.
Thank you.